I know that we're we're the obstacle that stands between you and cocktails, so we'll do our best to make this expedient. We'll go for about I think probably 15, and then we'll do questions for a few minutes, and then that'll be it. If that's okay. Sound good? Everybody all right with that? Everybody in? All caffeinated and stuff? All right, cool. I think you have probably seen Bechara's bio already, but you know that he's the Chief Community Health Officer for Kaiser Permanente, which is based across the bay in Oakland. And so I do want to talk mainly about the community initiatives that Kaiser's working on. But before we do that, let's just spend a couple of minutes on your history and how you come to this, because you started in public health and agency work in Chicago. And then now, since you're on the private side of healthcare, what's that transition been like for you? How are the sort of priorities and responsibilities the same and different?
Yeah. So first of all, thank you for inviting me to be here on the last Fireside chat before cocktails. So I had a non-linear career path, if you want. So I'm a family physician by training. I immigrated to this country to train as a family doc, spend my training in a healthcare for the homeless program and a program focused on immigrants and refugees. Was a clinician for about 12 years, seeing patients in Chicago, running a federally qualified health centers, and realized all along that it was so hard to get my patients to live the lives that they'd want to live if I'm only focusing on their healthcare. And I've realized that policy and government has a big role to play in empowering people to live the lives that they'd want to live. So I ended up on Rahm Emanuel's cabinet, running the health department for Chicago for 5 years. And now I'm part of an organization that's dedicated to improving the health and well-being of over 12.4 million members in communities where more than 68 million people live. And I'm so excited to be part of Kaiser Permanente.
Well, but bridge those two things for me, because with a city agency, for example, doing public health for a city, it's very clear that your responsibility is to the citizens there. You know, now, as you say, Kaiser has more than 12 million members. So, you know, nominally, you would say, well, the responsibility of Kaiser is only to those members. So what's the argument for broadening outward for example, $200 million on an affordable housing initiative, or the some millions that Kaiser has spent on dealing with homelessness in the Bay Area, a huge problem in the Bay Area, most of these folks will know.
Yeah.
How do you make that?
Yeah, so if you think about an organization like Kaiser Permanente, we're a non-for-profit organization that's dedicated to the health and well-being of our 12.4 million members. But if you think about it, when you think about what really impacts health, only 10, maybe 20% of what impacts health happens within the four walls of the medical office building. What impacts health are the social and economic factors in the communities where people live. So for us to be able to be a successful health organization, we have to be thinking about the conditions for health and equity in the communities where those members live, where our 12.4 million members live. And when we do that, when we focus on improving those conditions for health and equity, not only our members would benefit, but really everybody in the community would benefit. So for us, the work for community health is core to our strategy as an organization. Because for us to optimize the health of our members, we have to be thinking about the communities where those members live. And that's why that work is so core to what we do.
Let me be super cynical about that, though. Like, do you have outcome measures that you would trust that say that if you build X amount of affordable housing in the East Bay for anybody who needs affordable housing, that has a marked improvement, a measurable improvement on not just the health of the people who need housing, because that's pretty clear,
right,
housing, but on Kaiser members specifically? Like, can you make that connection? Or
yeah, well, I mean, if you think about it, when you look at a community like Oakland or San Francisco or the North Bay or in Southern California, where we have 40, 50% of the market, when you lift up the conditions in that community, you're lifting up everybody, including our own members. I mean, that's a clear in our mind. And at the same time, we also know that the conditions in those communities, when you take housing, for example, when we think about the housing crisis in this country, and particularly in this area, the housing crisis is a health crisis. I mean, we know life expectancy for people who are homeless are probably 27 years lower than it is for those who are housed. I mean, we know that. We know the total cost of care of people who are on the streets are much higher than those who are housed. You know, when people who are homeless gets admitted to the hospital, they stay 2 to 3 days longer, and when they're discharged, they're more likely to be readmitted. So when you create the right conditions to support people who are struggling with homelessness, you're supporting their health, absolutely.
But see, this is what I'm chasing. That sounds like somebody who runs public health in Oakland or San Francisco. That doesn't sound to me like somebody who's running a program or set of programs at Kaiser, Permanente. So I'm just like, internally, what are the corporate priorities?
Yeah.
Like
so let me give you another example. When you think about the social and economic factors in the communities where our members are living and how that is impactful on on the total cost of care, you know, probably about 3.5 million of our members live below 250% of federal poverty level. Okay. So when you think, and that's not just our Medicaid members or our Medicare members, that's also some of our commercially insured members. So those members, and they tell us, they have housing needs, they have transportation need, they have food insecurity issues, they have social isolation issues. So now as part of our process, we ask those members, and if they do...
sorry, on intake, or what's that like? How are you engaging with members about what those kinds of needs are in addition to sort of classical, you know,
So it happens when the patient and the doctors are talking to each other. It happens when a hospitalized patient is ready to be discharged, and then we want to make sure that they're discharged to a stable home, that they're not going to end up on the street. So we have multiple points where we're actually asking members, and we're trying to systematize and even improve more and more on the way we connect members to social services in the communities. And that's a concrete example of how you connect your business case to really doing the right thing for our members and the communities where we're in.
Right. So those are internal, and then you can also spend sort of, or have I guess, relationships with other organizations within the community too, to improve that when they leave too. I mean, is that?
Yeah. Oh, yeah. Absolutely. I mean, the thing is, you know, we're never going to be experts on housing people, but we partner with the right community-based organizations that are experts on housing individuals. Same thing for food insecurity. We support connections between members and food banks, or we support individuals getting enrolled in food stamps. I'll give you an example. You know, in California, we have about 238,000 Kaiser Permanente Medicaid members who qualify for food stamps but don't get it. And if you think about that, 238,000, multiply that by, you know, $150 a month per person, you're talking about $360 million of an opportunities that our members would qualify for, that they could access to get into their pocket to spend at their local grocery store to put food at their dinner table. So it's just a no-brainer for us to be engaged in this type of work.
How does that work on a kind of day-to-day? Like, are you in meetings with C-level folks saying, let's figure out what the priorities are going to be for the next year? Are people coming to you and sort of asking for, they wouldn't be grants, but to make these sorts of relationships? How does that actually work?
Yeah, so as a not-for-profit organization, we conduct what we call community health needs assessments. And we do those on a regular basis, where we have a fairly robust systematic approach to looking at data in each one of our communities, doing interviews with key stakeholders, key leaders in the communities, and looking at our own data, what we're learning from our own members, and define what are these community health needs that are out there in the communities, so we can develop implementation strategies to respond to those needs. And we do that regularly. We do actually over 39 of those in the country, where we take community by community, go through that process, and through a prioritization process, we identify the top priorities for each community, and we dedicate resources to make that happen. And when we're talking about resources, we're talking about a lot of resources. I mean, last year, we invested over $2.8 billion just in 2018 to support and respond to these community health needs in our communities.
Do you have a sense, though, that well, as an example, some of the research that I've read on homelessness says that part of the problem is that the federal government really stopped spending a lot of money through housing and urban development on providing housing for people. Do you have a sense that this is, in some ways, should not be the responsibility of a company like Kaiser Permanente? Like, this is something these are social services that you're now either in relationships with people who are providing or providing yourselves. Is that fair? Is that appropriate?
Yeah, I mean,
is that a business you want to be in?
Yeah, I mean, if you think about it, for us, this is not our cause and the cause for Kaiser Permanente only. We come to this with a lot of humility, and we come to this with a lot of other partners. And when you referenced the federal government, we absolutely believe the federal government has a significant role to play. And that's why last year we've joined a coalition called Mayors and CEOs for U.S. Housing Investment. And this is a coalition of about 20 plus bipartisan mayors who came together, and we're the national sponsor or national partner for that entity, and identified 4 or 5 key policy issues that we needed to work with the federal government on, and we are doing that. Same thing goes on a local level. We've launched an effort called City Health, where we've identified a certain set of policies that we know if cities adopt those policies, you're going to lift up community health in those cities. And one of those policies is around inclusionary zoning. So we are now working with the 40 largest cities in the country to make sure that that policy or those types of policies are adopted. So there's different ways. It's not just Kaiser Permanente is actively engaged in addressing homelessness in our communities, and we're doing that with our partners. Some are government partners, whether they're state, federal, or local, but also other not-for-profit, other businesses that are actually stepping up into that space as well. So
like, for example, in California right now, there's a bill working its way through the legislature. It's Scott Wiener's SB 50, which changes a lot of zoning, an idea of getting more housing built. It's a real problem in California. Is that something that Kaiser Permanente would also support as part of its legislative agenda, in addition to spending money on actually building housing?
So we do have a pretty robust policy agenda around homelessness, and it's also at a federal, state, and a local level. At the local level, we're really focusing on supporting cities, particularly the 40 largest cities, on inclusionary zoning. On a state level, it varies state by state. I know in California we've supported 1 and 2 last year, and now we're looking at what's out there to figure out which one we'd support or not. And on a federal level, we're actively engaged with the mayors and CEOs for U.S. Housing Investment Coalition. So the policy goes hand in hand. And the other piece, I think it's also important to focus on people. So I'll give you an example. Last year, we had a team from Kaiser Permanente's colleagues who came together from across the organization, and for 12 weeks spent 80% of their time working with the community partners in Oakland to try to identify what is it that we can do to make an impact on people who are on the street today. And as a result of this effort, we were able to identify 515 people. We identified them by name. Those are folks who are 50 plus, who are living on the streets, who have at least one chronic medical problems, and many of them have a lot more. And now we're partnering with the community on a concerted effort to get these 515 people off the streets by the end of this year. And we know these folks by name. So I would say it's a multifaceted approach. It is about policy. It is about putting the resources on the impact investing side. It is also about partnering with the communities to getting people off the street. And it's a partnership. It takes a village.
Just as a last thing, maybe before we go to questions, do you think that your both responsibilities and opportunities here change with the upcoming elections? Like, there's a chance, I suppose, that all of the Democrats will end up talking about either Medicare for all or even single payer. What do you see coming, and how do you think Kaiser Permanente will have to respond to it?
Well, I mean, Kaiser, as an organization, we've all been strong supporters of universal health coverage. We truly believe that we want everybody to be able to have access to affordable coverage as well as a high-quality health care. And even when you look at what's the situation been over the last few years, I mean, before the Affordable Care Act, we had about 54 or so million people in this country without coverage. As a result of the ACA, now that number went down to about 29 million. And when you think about those 29 million who are still without coverage today, probably about 2/3 of those, or over 19 million, already qualify for existing coverage options, whether it's expanded Medicaid, whether it's the subsidy on the exchanges, or it's the employer coverage. So when you look at the remaining 9.4 million, those are the folks that we need to figure out the policy solutions to expand coverage options to get them covered. So when you think about what do we need to do to get to universal coverage, I think it's about making sure that those folks who are insured, there is affordability components to that insurance, so those who have coverage, and making sure that the 9.4 million people who still don't qualify for coverage in this country get that. And that's why we've been big supporters of universal health coverage in this country.
Do you have a sense of what that'll mean? Will it depend on what the ultimate Democratic nominee wants? Like, is there a specific thing that you would support? If I say like Medicare for all versus single payer, is there some middle road there? Do you know what that looks like?
I think for us, it's been very clear that we're all about expanding coverage, getting more people covered, and getting that coverage to be more affordable, and making sure that the healthcare is high quality that people are getting. And that's really been our focus all along. And that's why we think building on the successes of the ACA and getting us to universal coverage is the right answer at this point.
Got it. All right. I landed almost, I'm looking at the clock, and tell almost ballistically about where we wanted to get to. Do we have questions from you folks? I think there are mics around too. If not, we can keep yammering, but I'll give a second to see if hands go up. Do you see one there? Hang on one second for a microphone.
Thanks so much for sharing. I really appreciate the discussion. We know that this is a big topic that people really care about in the country right now. You talked a lot about social equity. I'm super curious, like, what's changed with Kaiser? Was this always part of the discussion? Why are they having so much more of a focused impact now in terms of the work that they're doing in the community? Is it just because of ACA? What's really sort of changed?
Yeah, I mean, as an organization, as a nonprofit organization, we've always had a focus on community health. We've had decades of experience in working with communities around healthy eating, active living. We've spent a lot of time on supporting organizations like the panel before me was talking about, in grants and philanthropy. And now I think the understanding of what health is all about is continuously evolving, and the expansion of what constitutes health and what happens beyond the walls of the medical office buildings is critical part of why we're doubling down on our commitment to improving the health in our communities. And I'll give you examples that you might not even think about. An organization like Kaiser Permanente working with over 300 small businesses in our communities to support them to learn how to grow and draw down on more capital, hire more people. Because we know there's the same way there is a connection between housing and health, there's also a connection between economics and health. And we know that the more likely people are to be employed, they have more income, the more likely to be healthy. So those connections we're learning more and more about that, and we're becoming more, I think, clearer on the interventions that we know work, that there's evidence behind them that work.
Thank you very much. This has been really fascinating. Can you just speak for a moment about how these big topics that you've been addressing are translated into the employee engagement side of Kaiser's work life and employee volunteerism efforts?
Yeah. So I have to tell you, I mean, I want to start by just the anecdotes. And every time we make an announcement around issues like homelessness, issues like social needs for our members, issues like gun violence, when we kind of entered the debate around the importance of focusing on firearm injury prevention, we get an outpouring amount of response from our 220,000 plus colleagues across the country. And we're seeing that in engagement on volunteerism. There's a lot of folks who are interested in engaging in some of the community partners that we partner with. We have now a fully activated platform where individuals, colleagues go in and sign up for volunteer opportunities, create volunteer opportunities, and we're seeing a lot of alignment. I can't tell you the number of emails and calls I get from individuals sharing their personal stories, wanting to be engaged. One example of this is we've actually, as part of our understanding of what is it that we can do in the community health space or other spaces, we've launched what we've called a Challenge Possible effort, where we've asked our colleagues to say, we want to be able to meet the basic needs of our members. What do you think are good ideas? We've received over 1,400 ideas just from colleagues within the organization to actually lift up that work. And we've brought in a bunch of those folks together to identify the specific ideas that we'd want to work on and flush them out, and now we're investing in executing on them. So I would say there's been a tremendous interest from our colleagues across the country when it comes to community health.
People either, I was thinking people still need to find their courage before cocktails, but yeah.
Thank you. So you're obviously very passionate about the work you do, and I applaud that. And thank you for coming today. What my question is about is, from the community benefit perspective, how do you know when enough is enough? Because I know that community benefit functions off of the revenue of the hospital system, and oftentimes that's not dictated by a certain percentage. So how do you know when you've met that dollar figure and when it's enough, when you're talking about these very layered and multifaceted social issues?
Yeah,
I just want to amplify that to say also, how do you know when you're not doing it? Like Kaiser Permanente is profitable by somewhere in the billions. You could say like, well, all right, is this not just evidence that you are not taxed enough? Like, is there not somebody like is $200 million on affordable housing is fantastic, but it's obviously not enough in some global sense for everyone. Should it not also be more?
Right.
How do you find the right amount of dollars?
So we do track our community. Thank you for the question. We do track our community benefit expenditures year after year, and we are at about 2.8 billion or so this year. I think at the end of the day for us, it really all boils down to the community health needs assessments that we do. The reality is the needs are so huge, and there's no way that one entity can respond to all the needs, that even when we hear about all the needs and we tabulate them and we look at the data, it's just a huge problem to deal with. So we work with the communities to try to identify the areas that those communities would want us to work on, and we go through a prioritization process, resource allocation process, and that's how it works. And we track it regularly. I know as an organization, we track it yearly. I track it monthly or even sometimes weekly. Our board of directors is directly engaged. We have a committee of the board of directors that focuses on community health, that oversees all of our grants, investments in communities, contracts to support community health, supporting individuals and getting access to services. And that committee is very actively engaged regularly in those discussions. So it's not an easy answer, but it's something that we track very, very closely.
So last thing, we're slightly over time. As a lightning round, if there was one more sort of community benefit space that you could expand Kaiser Permanente into, if there's one more thing that you aren't doing yet that you'd like to, what would it be?
Yeah, I think I would say really stepping up our work on social needs for our members. That's really is key, because we're hearing regularly from our members that they do have issues with housing, with transportation, with food insecurity, with social isolation. And how do we do that at scale? So today we have over 35 different programs across the country within Kaiser Permanente that screen members for those needs and try to connect those members to services. But how do we take that to scale where all 12.4 million members, if they have that need, we can connect them to that need and close the gap? I think that's really what I'm really looking forward to this coming year.
All right. Bechara Choucair, thank you. Appreciate it.
Thanks.
Thank you.